Hello, my name is Giuseppe Rosano. I'm professor of cardiology at St. George's Hospital in London. I will be discussing how to manage heart rate in patients with heart failure. Uh, we know that the new ESC HFA guidelines suggest to start medical therapy with the four foundation therapies that include ACE inhibitors, beta blockers, MRA, and SGLT2 inhibitors. But also they suggest to phenotype patients according to the background conditions, and therefore suggest specific interventions according to heart rate, ischemic origin, presence of left bundle branch block, so on and so forth. And you can clearly see that there is an important place for heart rate reduction in patients with a heart rate greater than 70 beats per minute. So the message is we need to start medical therapy. We should implement all the four foundation therapy, but also we need to control an heart rate with in order to achieve a heart rate below 70 beats per minute. But also we know that if we want to implement medical therapy, that will take time, and because we need to start and up titrate slowly, and sometimes we have problems, especially with heart rate or blood pressure, or with the specific effect of some drugs. And therefore, starting and implementing all drugs together may take some times. Also, we have a problem in up titrating drugs like beta blockers, because in the real world, or even in trials where they've tested a forced up titration of beta blockers like bisoprolol and carvedilol, we can see that only 25% at most of patients with that underwent a forced up titration of beta blockers achieved more than 50% of the dose. This is because of side effects. It is because of the bradycardia, because of intolerance to beta blockers. We also know that beta blockers should be used according to the heart rate reduction rather than dose, and the meta-analysis in that respect have clearly shown that the efficacy of beta blockers on mortality and morbidity depends on the degree of heart rate reduction, but not by the beta blocker dose. We also know that in ivabradine is very effective alone or in association with beta blockers in order to reduce the composite endpoints in patients with angina, but also in patients with ischemic heart failure or with heart failure, where in patients with a heart rate greater than 70 beats per minute reduces cardiovascular mortality by and overall mortality by 17%. I think that, however, we have to, given the results of the SHAPE trials, where the majority of, or almost the totality of patients receiving ivabradine were also receiving a beta blocker, we have a clear evidence that achieving heart rate below 70 beats per minute is associated with a better prognosis. So regardless of whether we go on a beta blocker, we go on ivabradine, or in association with of an ivabradine plus beta blocker, then you can see that we have to move away from the old concept of threshold heart rate for treatment and go rather to target of treatment, and the target should be below 60 beats per minute. All the intervention trials that we have on patients receiving heart rate lowering drugs basically show that there's a sweet spot for heart rate that is between 50 and 56 beats per minute. This is where we have the lowest mortality and morbidity. So shifting towards the new paradigm, now we should aim for a heart rate, say, let's say around 54 to 56 beats per minute. We also know that if we start combination therapy with a beta blocker plus ivabradine, we have a better improvement in clinical status, left ventricular function, exercise capacity with combination therapy, but also that patients taking combination therapy achieve a higher beta blocker dose. So there is a sound rationale to start the two drugs together. The other problem is that in patients with an ischemic origin of heart failure and with still significant coronary artery disease, we also have to take into account that we shouldn't be too strict on reducing blood pressure, because the guidelines in patients with significant underlying ischemic heart disease suggest that the systolic blood pressure shouldn't be below 120 millimeters of mercury and the diastolic below 70. And it's for this reason that the Heart Failure Association of the ESC has come up with a new algorithm for patient profiles in order to give a better way of managing patients with heart failure according to heart rate, blood pressure, presence or not of CKD. And you can see that what the algorithm suggests is that whenever we have a patient that, despite full up titration, is still a high heart rate, we should be using ivabradine. In those patients where the blood pressure allows and still symptomatic despite the full foundation therapy, we should use other therapies on top of ivabradine. And also, what is important is that in patients with ischemic heart failure, the guidelines suggest that together with the beta blocker, we should be using, if they are in sinus rhythm, we always have to use ivabradine as indicated. So in conclusion, the medical therapy for patients with heart failure should be implemented according to the ESC HFA algorithm. They should be individualized to patient profile. And in those patients with heart failure and reduced ejection fraction and underlying ischemic heart disease, the rate control with beta blockers and ivabradine should always be pursued. And what is important is that we always have to watch in these patients the blood pressure that shouldn't be below 120 over 70 millimeters of mercury. And we have to switch to a new concept that is a target of heart rate treatment that should, with an aim of a heart rate between 54 and 58 beats per minute.